Are we going to start, guys?
I think we should start.
Great.
Go ahead, please.
Okay, so am I going to have anybody change the screen, or am I doing that myself?
Brittany will be changing the slides. Just tell her next slide.
Okay, so Brittany, let's get started then. Are we live now? Great. Hi, everybody. I'm Dr. Mark Surrey, and I am the medical director of Southern California Reproductive Center, and I'm here with our embryology director, Dr. Sangita Jindal, and we're going to chat with you today about reproductive technologies. I'm going to start by giving you a little background and then introduce Dr. Jindal, who's going to discuss with us some of the details of the technology that we're able to utilize now under her direction to perform assisted reproductive technology when it's indicated. So, Brittany, let's start. So, just so everybody knows who Dr. Jindal is, she is a professor and IVF lab director, and she's also now the president of the Society of Assisted Reproductive Technologies, which is a very prestigious position to be in that indicates that she essentially runs the society that regulates IVF in this country. So we're very proud of her for achieving this. And I know she's a little inundated by some of the administrative issues involved with it now, but you should know that she knows what she speaks of. So Brittany, let's get started with the slides. Firstly, SCRC, Southern California Reproductive Center, that we founded over 25 years ago and has offices in Beverly Hills, Santa Barbara, and Pasadena. And we service the Southern California area with several clinicians, several embryologists. Dr. Jindal is primarily located in the Santa Barbara facility. Dr. Jason Barrett, who is a well-known embryologist, is the director of the lab in Beverly Hills, and possibly in the future, a new lab in Pasadena location. So we have on-site availabilities for different surgical procedures as well as laboratory procedures involving studying hormone levels, studying sperm testing for men, and studying and evaluating people for what the best treatments are going to be for each individual. Brittany? So that's a picture of our Santa Barbara facility. Brittany? So in addition, just to give you a little background, the physicians, clinicians in our offices take sort of a holistic approach to reproductive medicine and fertility, to include focusing on your general health, including your nutrition, your sort of mind-body issue. We like to encourage things like meditation. We provide services to include acupuncture and nutritional counseling. So today we're going to talk a little bit about evaluation firstly. And let's start with age. So, Brittany, what we do know is that our fertility as human beings decline as we age. Brittany? If you look at the human ovary, and if you can take a look at the upper portion of this slide, we see that there is a gradual but significant decrease in the number of eggs that the human ovary has. And there is similarly a significant decrease in the ability of the eggs contained in the ovaries to create a normal pregnancy. Slide. That manifests itself in a diminished fertility, so that if you look at the left bar graph, you'll see approximate clinical pregnancy rates that are spontaneous per month based upon maternal age. And you'll see that at age 40, it is significantly less than it is at age 30. So between that decade of 30 to 40, there's a significant effect that age has. And that's why we believe that it is an excellent time to take advantage of the reproductive technologies that are available. So that if, for example, a woman is not actively involved in trying to conceive in her 30s, it is technically possible to preserve the eggs that she's producing at, for example, 32, to utilize perhaps when she's 42, because her fertility is significantly greater in that decade at 32 than it is at 42. And when we look at the right side of this, these graphs, we see that this also corresponds with a percentage of genetically normal eggs that we produce as human beings. And you'll notice that in the 40s, that can be less than 10% of the embryos produced. So it's significantly different. Slide. So let's start with trying to make an evaluation quick, simple, and time effective by speaking to the patient to get a history, doing some examinations, and some tests. And this can all be done within one cycle. One of the tests that we find to be really useful of what's called ovarian reserve is something called an AMH level. Stands for anti-Mullerian hormone, and it is specific to one's age. So we get a result from a blood test that can be done at any time during the cycle, as opposed to the traditional FSH test, which in theory should be done at the beginning part of a cycle and can vary depending upon the estrogen level that a person makes. An ultrasound is a really critical part of this evaluation, which will give us a really good image of the reproductive system, the ovaries and the uterus, and in combination with the AMH level, give us a very good picture of the person's reproductive capacity. Slide. The transportation system, which is critical for natural fertility, is something that can be evaluated by imaging. This is an example of an X-ray of the fallopian tubes, where on the right side they're closed and on the left side they're open. Slide. This is an example of a hysterosonogram looking at the uterus. On the left side is normal, on the right side is showing a polyp in the uterus, which is interfering with implantation of an embryo and can be excised hysteroscopically with a microendoscopic procedure available in most surgery centers. Slide. For guys, you're not all that complicated, but we need to look at a sperm analysis. And for a sperm analysis to be accurate, it's more than just the number of sperm and the movement, it's the morphology, the structural integrity of the sperm that requires a very specific trained laboratory to study this. And there's a significant percentage of people that are infertile because of the male factor. Slide. So let's think about treatment options. Well, a lot of people want to do inseminations because it's easy and it's perhaps less expensive than assisted reproductive technologies. IUI means placing a washed specimen of sperm through the cervix into the uterus that needs to be done when a person's ovulating. This represents natural fertility because in order for that to result in a pregnancy, fertilization and embryo development have to occur inside the fallopian tube. And because it occurs there, we can't look at it. We can't check it. We can't see it. We can't influence it. And as a result, inseminations don't work a lot more often than natural fertility does. Next. So it involves IVF when you want to make a different process enable us to see what's going on. IVF starts with stimulation of the ovaries because we know that a significant percentage of the eggs produced are not going to be normal. So more is better. So during the cycle, stimulation occurs with a naturally occurring releasing factor, comes from your pituitary gland called follicle stimulating hormone and luteinizing hormone that is administered underneath the skin for a number of days, during which time monitoring takes place with ultrasounds of hormone levels to see how you're responding to the stimulants. Next. And this is manifested by an ultrasound showing an increasing size of the follicle developing. Next. When we look at the results of these treatment options, even though the idea of medications for stimulation with inseminations is a relatively simple, natural thing to do, the pregnancy rates in these patients with a mean age of about 38 is somewhere for inseminations of around 10% per cycle. This same patient with in vitro fertilization will have a pregnancy rate in our center close to 80% per cycle. So there's a very big difference in the outcome of in vitro fertilization as opposed to a natural process. Next. So I'd like to have Dr. Jindal discuss with us this technology that works so well of in vitro fertilization. And Dr. Jindal, as I mentioned, is eminently qualified to discuss this, as she is the incoming president of the society that this country uses to regulate and supervise IVF labs. Dr. Jindal, pleasure to have you.
Thank you, Dr. Surrey. Very kind of you. And I'm delighted to be here. And I just want to remind participants, they are more than welcome to post questions in the Q&A section, which we will address after the presentation. So yes, as Dr. Surrey very kindly said, that I'm the lab director here in Santa Barbara, and I'm going to demystify the lab a little bit for the audience. So I'll start with the laboratory and the surgery center and let you know that the laboratory is a very highly engineered, a very tightly controlled environment. We have fresh air exchanges regularly per hour into the lab. This fresh air is filtered and warmed. We have positive pressure in the lab, which prevents intrusion of any non-fresh, non-filtered air. The lab staff follows very strict protocols for entry into the space. It is restricted. What they can wear, including perfumes and lotions, hand washing protocols, etc. I dare say that the laboratory is the cleanest space in the entire IVF clinic. Next slide, please. So what does our laboratory offer? And I'll go quickly through this list. Certainly an experienced and certified lab director. I have been doing this for over 24 years, and I am a high complexity clinical lab director. We have a double witnessing verification program, which means that we very strictly have 2 sets of eyes on every touch point when eggs and embryos are being handled in the laboratory. We culture to the blastocyst stage. This is the gold standard of culture when an embryo is taken all the way through day 5, day 6, even day 7 of culture in the incubator. We do vitrification. This is relatively new in human IVF, about 10 years. It's basically flash freezing, which results in very, very good recovery rates of embryos after they're frozen. And the embryos that are thawed and transferred result in very high pregnancy rates. We do biopsy of the embryos at the blastocyst stage. And there's 2 types that we biopsy, and we test in 2 ways. We test for aneuploidy, which is PGTA, and I'll talk about that in a minute. And that's really to determine whether the embryos are chromosomally normal. PGTM addresses specific gene mutations related to disease states. And so couples would come in and ask for PGTM specifically. We do whole genome amplification, and all 24 chromosomes are analyzed, and we offer sex selection as well. Last but not least, we have an embryoscope, and I'll go into that in a minute. That's basically a time-lapse video analysis. On top of all these very high-tech features, all of this is predicated on good tissue practice. So I want to take you through the details that we observe to make sure that everything is sterile and correct in the laboratory. So all the dishes, tubes, catheters, syringes, etc., used in the lab are sterile, plastic, and disposable. Nothing is reused. We purchase fresh culture media monthly, and the quality control from these manufacturers ensures sterility and the correct concentrations of water, proteins, amino acids in the media. And this is all to support growth of the embryo. Dishes are permanently marked with patient unique identifiers. Each patient has 2 unique identifiers, usually their name and date of birth. The media is placed in clean labeled dishes the day before the culture begins, and these dishes are placed in the incubator. A specific mixture of gas, medical grade, goes into each incubator, which works with the media in each dish to maintain physiologic pH and osmolality, both of which are needed to culture eggs, sperm, and embryos so that they grow as best they can. All lab surfaces are heated to body temperature. And this is so that when we work with the eggs and sperm and embryos outside of the incubator, there's very little disruption or stress on the embryo from changing lab conditions such as temperature. We only work with one patient's eggs, sperm, and embryos at a time. And the laboratory is responsible for all eggs retrieved and all fertilized eggs, all the embryos that develop through the cleavage stage to the blastocyst stage. Next slide. The most common form of combining egg and sperm is through ICSI, or intracytoplasmic sperm injection. As you can see on the right, there is a panel showing an actual human egg under the microscope at 400 times magnification. The holding pipette has applied gentle suction to hold the egg in place, and a fine glass injection pipette is used to pick up the sperm and inject the egg. This is a very technically demanding process that requires training and regular competency assessment of trained staff. Once the eggs are injected with a single sperm, they're placed overnight in the incubator and checked the next day for fertilization. Next slide. And here's an image showing development of the fertilized egg through all the stages, the fertilized egg to the 2-cell stage, 4-cell, 8-cell, 16-cell, and finally the blastocyst. So the blastocyst is comprised of 2 cell types: the inner cell mass, which is destined to become the fetus, and the trophectoderm, or the outer layer, which is destined to become the placenta. At the blastocyst stage, the embryos undergo biopsy for genetic testing. And this is what we referred to before as PGT, pre-implantation genetic testing, for aneuploidy. Up to 5 cells are removed from this trophectoderm layer of cells. Next slide. Here's a time-lapse video. Hold up. Oh, okay. So this is a time-lapse video showing the development of a single fertilized oocyte in the embryoscope. So you can see it's developing all the way through. This is over 5 days of culture to a beautiful blastocyst. It can play again while I describe it. So this is every 20 minutes, a dark field photo is taken of each embryo over the entire culture period. It's put together as a video, and this video is reviewed by the lab staff to confirm that the embryo development has proceeded normally. After reaching the blastocyst stage, this embryo would be biopsied. So again, for the last time, we'll take it through. The cleavage stages: 4 cells, 8 cells, 16 cells, now a morula. It's about day 4. Now it's day 5, beautiful blastocyst. Thank you, Brittany. Next slide. Here the embryo stages are shown once again. The 2 pronuclear stage in the top left panel, showing the male and female chromosomes that are aligning on the centriolar plate. And then it moves to a cleavage stage, a blastocyst stage, and finally a hatching blastocyst. In the panel on the right, the blastocyst is being biopsied. This is all done under high-powered microscope, again at 400 magnification, using fine glass needles, one that holds the blastocyst in place and one to apply section to pull the cells out of the blastocyst. Cells are pulled out and cut off using a laser. The cells are sent off for genetic testing, and the blastocyst is frozen. Once the genetic test results come back, we know which blastocyst is considered chromosomally normal. That's the one that we thaw. Typically, we transfer 1 blastocyst on day 5 or day 6 of development into the uterus. Next slide. This slide shows IVF success with maternal age and genetic testing. So I'll take you through the slide. So at the bottom, we have maternal age, and these are organized into groups: less than 35 years of age, 35 to 37, 38 to 40, and 41 to 42. Each column shows the implantation rate for each age group, which means how often an embryo implants in the uterus. The percent of times that an embryo implants in the uterus declines with maternal age. And this is what Dr. Surrey alluded to in his presentation, that chromosomally normal eggs, the number of which decline with maternal age. Without genetic testing, or the no PGTA group in orange, the percent of times that an embryo implants in the uterus declined even faster with maternal age. However, with genetic testing, or the PGTA group in aqua, the percent of times that an embryo implants in the uterus is much higher compared to the no PGTA population. So what this means is that the genetic testing of the embryo that is transferred back to the patient contributes to a higher implantation rate. We are putting back chromosomally normal embryos, and these embryos implant in more patients more often, including our older patients. Next slide, please. So yes, today I wanted to introduce this audience to SART, or the Society for Assisted Reproductive Technology. SART is a unique organization that self-regulates and monitors IVF and assisted reproductive technologies, ART, programs in the US. SART reports our IVF statistics nationally, which we are required to do by law. It sets standards and it issues guidance for IVF programs nationally. It also provides significant member benefits, which I'll describe in the next slide. So some of them are listed here. There are resources for education and information for patients and practitioners. There is an executive council that is elected and appointed, which is comprised of leaders in the field. SART's focus is on integrity in reporting, access to care for patients, and maintaining standards. Because of these maintenance of standards, there are requirements for membership, such as the physicians, fertility experts maintaining REI certification. Laboratories must be accredited, and they must follow all advertising guidelines on their websites. The Executive Council, I won't read all the names here, is comprised of many experts from all different aspects, including mental health professionals, nursing, legal, research, physicians, laboratory, and so on. In addition to all the values listed here, SART also generates consent forms, templates for their members to use. They offer podcasts, webinars, predictor tools, and very importantly, it generates de-identified data for research, which helps refine our practice for patients. Next slide. So this slide shows SCRC's pregnancy rates compared to the national average, which was reported last in 2020 by SART. This is the most current public data available. As you can see, SCRC in AQUA has a higher, and in some cases much higher, pregnancy success rate for their patients compared to the national average when categorized by maternal age. Being a SART member clinic is the gold standard in the field of IVF. And I'm happy to share that as of October of 2022, I will be serving as SART president with national oversight of over 95% of IVF cycles performed in the US. Next slide. So I think, yes, we just want to acknowledge and thank our fertility team. All of these physicians are affiliated with SCRC, and of course, Dr. Surrey in particular. Next slide. And I think this is to you now, Brittany.
Yes, I'm going to discuss some of the promos that we are running right now. We have a $6,400 egg freeze special, and that's going until the end of August. Our second promo is freezing your eggs with your friends. So if you have another friend who wants to freeze eggs with you, each of you would get 25% off. If there's 3 of you guys that want to freeze eggs together, you guys get 30% off each. And that runs until the end of this year.
Okay. So why don't we open the Q&A session, and I can read some of the questions. If there's anything we can answer, we'd be happy to do that. I see there are a couple of items in the chat as well, but I guess I'll open Q&A.
Can we go back, Dr. Jindal, to your last slide showing SART statistics and results most recently? I just wanted to comment, if you look at the patients over 40, you'll see a profound difference, which is almost double SCRC compared to the national average. And why do you think that SCRC is so much higher than the national average from your perspective?
Yes, I think that's a great question. So our patients should know that when we treat patients in that age group, we are transferring only chromosomally normal embryos. And I think that that is what sets us apart. When you look at national SART data, that includes patients who have embryos that have not even been tested, includes tested and untested. So because we are maximizing every chance we can for our patients, especially in that age group, I think the rates reflect very well that we do well by these patients.
The other thing to mention is the average number of embryos transferred at SCRC is just a little more than 1 per patient. So we don't transfer multiple embryos.
Yeah, very true. And I think that's a trend nationally. I'm glad to know that SCRC is right in line with that. Mm-hmm.
Right. So
Okay.
the idea is to minimize issues that can be presented with multiple gestations, as well as create the best result for the patient. So we're happy to take any questions that you may have. And Dr. Jindal, you want to start perhaps?
Yeah, I can read the questions. They're probably mostly for you. So
Well,
let me read the first one.
Sure.
Somebody's asking if there's any way to evaluate egg quality or grade egg quality alone without creating embryos. I guess I could answer that one.
You could, yeah.
Yeah. So, so yes, we see the eggs under the microscope at time of retrieval. We do clean off the eggs and take off all the cells, and we are able to see the egg very clearly. So we do a qualitative grading of the eggs at that time, but we do ICSI everything that we can that's mature. So we're evaluating the eggs for maturity, and certainly we have about 70 to 80% maturity per case. And so that's the sort of thing that we're looking at. Other than that, we only remark on things that are very unusual, and that's rare. It's not all eggs at all for any patients. It's 1 or 2 eggs that may not be mature. They may be profoundly immature. They may be shaped differently. So we'll comment on that. So yes, we do grade the eggs at the time of retrieval. Next question.
I think the next one may be for you as well.
Oh no. What can mitochondrial replacement therapy do? Oh my, for poor quality or immature eggs. How soon do you think this will be available in America? Oh my goodness, somebody's been doing the research. So yes, this is definitely something that is an area of active research. I am not confident when it will be applicable clinically in the US. It is not considered standard of care. And the concept is correct. Mitochondrial replacement therapy, in theory, could help the biochemistry of the eggs if they are not functioning well on their own, but that is not something that's clinically available, and I cannot really advise when that would be the case. Number 3, do you recommend priming for anything for a 39-year-old with an AMH of 0.6 and an FSH level of 13?
So this patient has a diminished ovarian reserve, and it's common to prepare or prime people like this with exogenous estrogen therapy.
Yeah, E2 priming.
So tips for how to go about choosing donor sperm. First of all, you have to be, I think, selective in regard to the place you're using, and there are regulations that the place the sperm bank should adhere to before using them, and you should probably adhere to those recommendations depending upon the sperm bank that you use. So that's the best answer to that, I think. But you have to be comfortable then as well with the information that you get about the donor so that you can adequately select the donor of your choice.
Yes, I just want to add to that. Thank you, Dr. Surrey. There are a number of national sperm banks that have high quality screening that are required actually by law. This falls under the FDA, and we work with those banks regularly. Next question, the patient, or the participant would like clarification on the 80% successful IVF with unexplained infertility versus what? So I think the 80% referred to all patients, all comers.
Yeah.
Yeah. Sorry, that wasn't clear. It's to all patients. How do you know when it's better to use a day 3 embryo versus a more developed embryo? So typically, maybe 10 years ago, the standard was to transfer on day 3, and we didn't really have the culture media or the incubators to support growth past day 3 reliably. But now the standard has shifted to blastocyst, which is day 5, day 5, 6, 7, but we, transfer with day 5. And so that is the standard. And we know that if the embryo can grow in the dish, in the incubator, undisturbed in this media to day 5, that has a much better chance of predicting your chance for pregnancy. And it allows us to transfer a single embryo. On day 3, it's very it's not typical to transfer one embryo on day 3. And so you'd have to transfer multiple embryos because they're a much earlier stage, and that's just not the standard anymore. I'm not sure if that answers the question. Perhaps Dr. Surrey, you might comment on that too.
Transferring day 3 embryos is sort of like 1989 IVF. It's the way things used to be done when there was a suspicion that the quality of the environment the embryo was in could adversely affect its development. And I think with the advent of the quality of IVF labs improving to the point of their current status, which is such that it's almost better than a natural environment, it allows us to adequately evaluate a more developed embryo, as well as genetically test it, which has been shown very clearly with Dr. Jindal's statistics to, particularly with older patients, significantly affect pregnancy rates in a positive way by almost doubling them. So I guess maybe administration can answer the question about the cost of the initial consultation, which is going to vary from person to person depending upon what they might have. But, I think the clear message is that we want to make it easy for somebody to walk in. So if anybody has a financial problem, they should speak to the business office to try to get accommodations. Let's see.
The next question is, if a patient is okay with having twins, could they request 2 embryos to be transferred?
What do you think, Dr. Jindal?
I don't think so. I mean, we can definitely talk about it. It's a case-by-case basis, but our policy is 1 embryo, and there's a good reason for that policy. But it's up to you, Dr. Surrey.
Well, I think it's like a lot of things. It's called informed consent. And, the patient is going to have to be okay with the potential consequences of a twin pregnancy. And, so everybody's different, and it requires a lot of counseling. But, if somebody's adequately counseled and is, anatomically okay, as evidenced by the evaluation of the uterus, as well as their own, physical examinations, then, it's possible. So it depends is the best answer.
I would say so, case by case. The next question. Oh, I'm so sorry.
Yeah, I was just going to read it.
Go ahead.
After egg retrieval, how soon do you start the next process for a transfer, what does that process entail? And firstly, it depends upon the evaluation of the embryos before you can do a transfer. So you don't really know for usually up to a couple of weeks how the embryos are evaluated. The process of preparing for an embryo transfer also varies from person to person. And it can include preparation in a natural cycle to a prepared cycle, which involves taking a combination of some estrogen and progesterone hormones. Let's see, do you accept outside lab work results? It depends upon the lab and the results, but if you're speaking of hormone levels, usually so. If you're speaking about embryo evaluation, on occasion. So let's see, what are the advantages of luteal phase stimulation when you choose this over standard follicular phase stimulation? Can you do estrogen priming with luteal phase stimulation? So first of all, there are sporadic advantages to luteal phase stimulation that usually apply to someone with low reserve. And so, yes, it is possible to do estrogen priming with luteal phase stimulation. Let's see. What's the process and timeline from consultation to retrieval of eggs? Is that the question?
Yes, for freezing. Yep.
It should be relatively quick. So I would say within a couple of months. Dr. Jindal, PRP. Protein-rich plasma.
Yeah.
It's been utilized in some places to improve diminished ovarian reserve. There's no good data that it works, just to be brief. So we don't know, but we don't think it's particularly beneficial.
Yes, it's a new non-standard treatment, innovation, but it has not been proven. I would agree.
So if there are any other questions or comments, we're more than happy to entertain them by email, by phone consultation, or whatever is appropriate for you guys. So any of us would be happy to see you at your convenience. And Dr. Jindal, anything else on your?
No, I just, I welcome all patients to our Santa Barbara office. We'd be delighted to help you build your family and wish you all the best.
Great. All right. Everybody have a good evening, and we'll look forward to hearing from you. Take care.
Yes. Bye-bye.